didn't know if I had to compete with the music, so thank you for ensuring that we have kind of a quiet room for what I think will be a really vibrant conversation today. I am so thankful that this is in some ways not only the final but also concluding conversation of the conference because kind of how we think about the governance of health systems but also global health priorities is clearly crucial to not only whether or not progress toward any specific or systemic health goal will be achieved, whether it will be achieved kind of efficiently, effectively, and also ultimately equitably. And I think we have a really terrific panel with us this afternoon, and am looking forward to listening to each of them kind of reflect on these questions of global health governance, and then look forward to exploiting my position as a moderator to ask a few questions, and then really looking forward to kind of hearing whatever questions you may want to pose to any of the panelists individually or to us collectively. So the first person we'll hear from today is my friend and colleague, Laurie Garrett. I remember reading The Coming Plague now more than 20 years ago and have kind of looked up to her kind of ever since, and I'm so thankful to have had the chance to work alongside her, and I always learn something from her every time I have the opportunity to listen in formal or informal settings. Then we'll hear from Dr. Inez Sukkot, who currently is the director at the Department of Health Systems, Governance and Finance at WHO. It's quite a mouthful to say. It's clearly even kind of a bigger job to tackle on any given day. She was formerly at the World Bank and before that at the African Development Bank. So I think she has a particularly important perspective on financing and how it relates to this broader kind of conversation. And then we'll hear from Dr. Willie Mutunga, who's the former Supreme Court Justice and head of the Supreme Court from Kenya, who pays particular attention to how we should think about human rights in any governance conversation, something that I don't think anyone would argue has been far too long neglected. So I just want to now turn the floor over to Laurie, and we'll kind of go sequentially down. If the ghost at the end of the panel wants to contribute something, we'll be happy to hear from her as well, because of course she's a her. And then just really looking forward to the subsequent conversation. So Laurie, the floor is yours. I think wherever you want to be is the right answer.
Podium or here? Podium. Here. I'll go here because the podium control device is sitting here. And thanks very much. And amazing that Chelsea found time to be with us, given that she's on book tour for She Persisted, which is getting a huge reaction all over the world. Congratulations. You know, she's a kid and it's her third book. Shames the heck out of some of us. Okay, let me just jump into this because I'm going to be covering a lot of material. It's going to be very data rich. It's going to go very fast, so fasten your seatbelts. Because we've started off with a global health effort that very much hitched its wagon to globalization. Everything that you in this room care about was tied to the rise of the G7, the rise of the G20, the World Economic Forum, and large-scale concepts of globalization, and it worked. We had a huge increase in resources pouring into all global health programs, with the exception of WHO, which had the same amount year after year. And it led to a whole set of new multilaterals and to a very complex governance structure, if you will, so chaotic that there was a lot of talk of reform. And by 2016, we were really looking at trying to reform all these institutions, bring them in better alignment, and so on. However, we've had a tough row to hoe, in large part because we grossly underestimated the scale of the problem in terms of reform and the scale of the problem in the global landscape. I'm of course talking about the retreat from globalization that has occurred. Let's first remember that the ascent before the world financial crisis 2008-2009 was about a globalization that brought resources addressing global public goods and was about open trade, cutting down on tariffs. Post-2008, we're going the opposite direction, restoring tariff structures and boundaries to the movement of world capital and a decline in commitment to global public goods. As was summarized by Michael Spence, Nobel laureate in economics, every single part of the globalized economy is now under assault. There's not a single piece of it that isn't being torn asunder, and it's driven by attitudes towards refugees and immigrants. We've seen a 177% decline in cross-border movement of financial wealth. That's phenomenal. That means it's not just a decline in public goods investment, but direct investment in other economies. Dr. Tedros, the leader of WHO, has made it clear that we're in a moment where isolationism and nationalism are on the rise, and this runs absolutely contrary to all the principles of global health and the very basis of where we want to go. We are tied to globalization, but we've gone from this moment to this one. And it means that we are grossly challenged in a way that would be hard to overstate. Let's just start with commitment to multilaterals, not just the United Nations, but the full range of multilateral institutions. United States commitment has already plummeted. We have a Congress that's out to destroy, and it will continue to go down. This means resources for every one of the allied institutions is going to decline. But it's not just America. We're seeing the rise of nationalism, far-right movements, and populism all over the world, most recently in the last few days in Italy, with an absolute increase in overt fascism, the return of idolatry of Mussolini in Italy. Now, the problem is that you can't do governance without money. So I'm going to take you through two key issues. Where is the money coming from? What are we going to do about that? And secondly, what does this mean about the larger trend that is occurring in the background, changing from global health to something new, some new concept of world health, with more country control and, frankly, with more China forward? So let's start with the financing. Where are we? What kind of money is flowing? Well, before this moment, we already had excess dependence on the United States, both for the United Nations associated institutions and, in the orange, all the other multilaterals that are not directly affiliated with the United Nations. The dependence on the U.S. has been enormous. A new report just out from the Brookings Institute breaks this down and reaches some startling conclusions about where we stood before Trump began to make changes. Over a 2-year period, we were looking at about $63 billion in the ODA space for health. It went to 53 multilateral institutions. By the way, this isn't just health, it's all multilateral UN efforts, and huge dependence on the percentage coming from the United States. I would call this dangerous dependency. If you look at the range of acronyms, you don't even need to know what they all stand for, but every one of them heavily, heavily dependent on money from the United States of America. Humanitarian relief in particular is very much driven by U.S. government support. Your average natural disaster or famine. And this whole new concept of global health security and preparedness for epidemics and pandemics really came out of the Obama administration, and despite attempts to raise money from multiple other sources, has remained very much a United States government-backed effort financially and in skills and talent, as we heard in a session yesterday here at the gathering. Some of us have said, well, is it right to turn to a private wealthy person to pick up the pieces and fill in the gap? That's a larger question, but in truth, Bill Gates is the major piece filling in. So if you add together money from the UK, money from the US, and money from Gates, you're approaching 60% dependency on just 3 sources. Along comes Brexit, And that British commitment is very much up for grabs. Nobody knows how the dust is going to settle in the UK over the next 12 to 15 months. And of course, along comes Donald Trump. We had a situation where the two Washingtons were really driving global health, whether you liked it or not, because they controlled the money. And by controlling the money, they controlled the institutions directly or behind the scenes. Now, doomsday may have arrived, because one of the major funders, the number one funder, is saying there's strings attached now to our money. And the UK is saying there's strings attached now to our money. And these strings are political strings. You play ball with us. And now the firing of Rex Tillerson signals the rise for the first time in the history of the United States of America of a truly right-wing foreign policy. Unfettered. If you thought the Bush administration was a right-wing foreign policy, you're wrong. They actually believed in the liberal order. This new regime does not. We don't know where this is going to settle, but it certainly looks like white lives matter more than black lives. Light-skinned lives matter more than dark-skinned lives. Countries of light skin matter more than countries of dark skin. European money has tended to stay inside Europe and the Middle East. Even for HIV, about half of all foreign aid stays inside the Eurozone. So Europe's not in a position to step up to the plate and fill in the gap. Meanwhile, we have a new model of world health emerging. And it is coincident with the financial shift, but was originally pushed by optimism. A huge decline in extreme poverty in the world, even in the poorest countries on the planet, has offered the possibility put forward by the World Bank that we can directly attack poverty. And we've seen a huge increase within countries all over the world in their own domestic spending for public goods, both from public and private sources. That's a good sign. And it's led to the optimism, as laid out in a brand new paper published this week by Ariel Pablos-Mendez and Mario Raviglione, of going to a new model for global health. So you go from the colonial tropical medicine days all the way through to a new continuum that is country-controlled and that takes less and less of the top-down approach to setting policy and moving resources. A very exciting possibility, but there's danger ahead, and we may not make it, because dependency on country resources assumes countries have that money, assumes they can manage. Well, let's look at what's going on in Africa. This from The Economist. A huge increase in African debt is looming, and it's because it's commodities-based economies, extraction-based economies. These are not stable in the longer term. And we have a paradox that more nations are moving into middle income status, but fewer and fewer humans are genuinely middle class. In fact, in the United States, since 1962, we've had an absolute reversal in the percentage of our population that's middle class versus super rich. And we're seeing a similar kind of slightly less stark reversal all over the world. At the same time, we're seeing a decline all over the world in spending on public sector, with an increase in private sector spending. What this means is more and more money is staying inside of corporations, staying inside of personal family wealth, and less is going to build roads, hospitals, schools, all of what you call public goods, put right at the top of that list for this crowd, global health institutions and domestic health institutions. Finally, we have the problem that since 2008, more and more of the super wealth money has moved out of taxation. It has gone to the Cayman Islands and other places, 10% of global GDP. So if we look at the trends of where are we heading right now in a large-scale investment in health, from the United States, this is the larger trajectory. Of course, Congress might pull a miracle out of its hat and say no to Trump, but I doubt it. And this is the breakdown. I'm sorry, it's a small scale, but overall, the CDC would lose 10% of its budget, and a lot of programs would be either 100% deleted or up to 50% deleted, and you can see the list. It's a terrible prospect. If you look across largely, PEPFAR is scheduled for enormous cuts. The Global Fund for an even higher percentage of cutting of its programs. Not a single global health program in the US budget would go spared. and many would be drastically cut. Now, I was just in a session on HIV chaired by Wafel Sadr, and one of the things that was being discussed is, are we at the hyper-hope moment with HIV? Well, the hope is we've got more and more people living, more and more people on ART, but the death rate is still down around 1 million a year, and the new infection rate is around 2 million a year. That means if you do the math, we have danger ahead on the HIV front, and it could lead to a second great pandemic if we don't have resources to get another 16 million people on antiretroviral therapy and keep them on therapy for the rest of their lives. We could very well see a resurgence in HIV on a grand scale. And this is when they're talking about cutting PEPFAR. They're talking about cutting HIV-related resources, a very dangerous moment. So overall, if you look at the gap between the imagining of self-reliance and the reality, it's profound. It's staggering. And anyone who's walking around with a big smile on their face is going to have to explain the basis for their optimism. Now, the one big shift that is occurring is that China now just about equals the United States as a foreign aid giver. And they've just this week created at the Politburo level a whole new entity for global health and for all development writ large. However, let's not go overboard. It's heavily focused on recreating the Silk Road, which is a giant trade scheme involving 60 nations circling all trade through China. So building hospitals and clinics along that road is their prime issue. Bottom line, it leaves us asking, when we look ahead at the great challenges we face down the road, whether it's climate change or antibiotic resistance, whether it's the use of CRISPR to create deliberately man-made microorganisms, whether it's microplastics in our environment, or the rise of pollution across the world, or the looming great pandemic that surely will eventually come, we don't have a clear sense of who's in charge. We don't have a chain of command. We don't have any clear governance of almost any of these issues. If HIV comes back and resurges, do you really think UNAIDS is up to the job? If Andrew Wakefield gets an even larger following claiming vaccines cause autism, who is going to counter him? Who saves the world's lungs in the form of the coral reefs? Who cleans syringes out of the global environment? We don't have a structure in place, and we don't have a leadership pyramid up to the task. Thank you.
Well, that was a fantastic speech. And if I may continue on this journey about science, money, and politics, I will start with a quote from Dr. Tedros, our new Director General from WHO. Universal health coverage is ultimately a political choice. It's the responsibility overly of country and national governments to achieve it and to pursue it and achieve it. So if we look at the SDG health price tag, we actually do have the numbers, but the question is now, how do we split the bill? Progress on SDGs has been remarkable over the past 2-3 decades. The progresses on health have been, if anything, amazing, alongside the progress on poverty. If you look at the proportion of people who receive less than 3 essential health interventions in the area of maternal child health, communicable disease, and non-communicable disease, you see that this proportion of people not having access to any services, not being reached by any services, has dramatically decreased. And particularly this decrease has happened among the poor. We see that the rich were doing well already. This has happened in the 20th century. But in the 21st century, what we are observing is a dramatic improvement of the access to services for the poor. And we have an increase in the proportion of people who have access to more than 10 services, essential services that contribute in a dramatic way to survival and mortality reduction. How can we go further, however? The poor are still doing less well than the rich. And according to most of what we can bring together in terms of evidence, we can see that investments in health system could actually help prevent an additional 97 million premature deaths by 2030. So further progress is possible. It is possible technically to achieve the SDGs by 2030. Meeting these health SDGs would mean investing about 3.9 trillion over the next 15 years. It's basically about 300 billion annually by 2030. That is about $76 per capita in the low-income countries, 58 in the low-middle-income countries, and 51 additional in the middle-income countries. And this would be mainly about 34% in infrastructure, 36% in health workforce, and then the rest between drugs and consumable, supply chains, and health system strengthening in the area of financing and governance. This would offer us 97 million lives, 535 million healthy years of life, with an additional 23 million health workers and more than 400 new health facilities. How would we reach that? What is fascinating when we look at the structure of this cost, you see that most of it cannot be achieved by a people-centered model of services of primary health care. This is about policy and population-wide interventions in the community, cross-sectoral, not really requiring high-tech services. It's about periodic outreach to the most deprived populations through mobile services. It is mostly about first-level clinical services, about 60% of it, and some level of specialized care with an environment of support through supply chain financing and health information. But as you can see, it is together more than, close to 80%, more than 75% primary health care. What are we spending today in relation to this number? So actually the WHO last December produced a set of new metrics on healthcare financing and reanalyzed the trends in health financing over the past 15 years. And what we found is that over the past 15 years, health expenditure systematically grew faster than the global economy. In low and middle income countries, economic growth was at around 4% per year, while the growth of the health economy was about 6% per year. So in 2015, the world spent about 7.3 trillion on health. That is about 10% of global GDP. And if the health economy would be a country, that would make it the third economy in the world. And yes, Laurie, domestic public finance is what is key to achieve universal health coverage. And what we see is in high-income countries as well as in middle-income countries, we see this transition in health financing in which more and more people live in countries in which public financing is the dominant source of financing. And more health financing is funded through collective arrangements, be it national health services, tax-based, or social insurance mechanism. But what you see at the bottom is we have an exception there. And that is the low-income countries in which we actually see a decrease in domestic spending, which is actually very worrying. And when we try to drill down in those statistics, we see that we have an incredible level of fungibility that has taken place. So in low-income countries, the share of spending from external sources over these 15 years has increased from 20% to 30%. That's what you see in red. But in the meantime, the domestic public spending on health reduced. So we have an effect of displacement and offsetting of domestic expenditures by external funding, which is really a call for all of us to revisit how we go about external financing and how we can somewhat shift back to financing more public good, more common and global public good, and somehow rebalance the flows of external financing to invest in systems that actually trigger increase in domestic financing. Because the role of development assistance in health is essential. It's particularly essential for global public goods such as research and development and the preparedness to pandemics. But when we look at the figures and the amounts, the development assistance of health is that small point here. Sorry. That small point at the bottom, that little ball in white of about 20 to 25 billion, depending on how it is counted, either through national health accounts or through flow of external assistance. These 20 billion compare to the 7.3 trillion of health expenditures globally and the 4.4 trillion of domestic public expenditures. So as we see that we are right now in a phase of very rapid economic growth, particularly in emerging economies like China and increasingly India, who is now growing at about 6% per year, will have less and less reliance on external aid. Already in 2015, external aid represents less than 1% of health expenditures in upper middle income countries, those emerging economies. It's about 0.7% of health expenditures in India. That means external aid doesn't matter anymore in India. Even in low middle income countries, it's less than 3%. So it's only in a shrinking number of countries, at about 30, 35 countries, that are low income and mostly fragile and often in conflict, that aid continues to matter when it comes to the expenditures in the country, representing about 30% of health expenditures. So if we look at how much we would need to inject incrementally to achieve the SDGs, we see that this amount could be funded mostly through domestic expenditures. So already today, in low and middle income countries, we have 97% of expenditures are domestic, and the incremental amounts that are needed to achieve the SDGs could be funded with reasonable assumptions on economic growth, reasonable assumptions on efficiency of taxation, and politics that would lead to better allocations to healthcare. About 85% of what is needed to reach the SDGs will be just happening through economic growth, leaving about 15% that would be still needed for additional investments of external financing in this about 30 to 35 low-income countries. So the question is, if reaching universal health coverage is technically possible, if reaching universal health coverage is financially possible, then we are left with politics. Technically possible is science. Financially possible is economic growth and taxation. We are left with politics. And what are we up against when attempting to improve aid efficiency? Remember the problem that we have of offsetting, the problem of capture of aid monies. We basically are left with three main actors, three main stakeholders. People at the center. The market providers, the private sector that delivers services, that delivers goods, that delivers supply chains, that delivers pharmaceuticals, that delivers labor, the labor market for health workers. And then governments, politicians and policymakers. That is the triangle of accountability, the triangle of politics. And of course, poor people are at the center of that. Poor people are the ones who produce health. but they are also the users of services, they are the client of services, and finally, they are the citizens. They are the ones who, through their voice, create the demand, create collective action, and put pressure on the politicians they have chosen to do the right thing that is needed collectively. So the role of collective action will be essential over the next 15 years to mobilize this funding that will be there towards those actions that are necessary to reach the SDGs. And the problem we have when we talk about external aid and we talk about those 35 countries that still need this support is that we have two triangles of accountability. We have the triangle of accountability on the right here of the recipient at the country level, and then we have the donor triangle of accountability. And usually what is happening is when the donor interacts with the triangle of accountability at country level, it doesn't interact with the people. It interacts with the agency. It interacts with the government. So then we have really an agency issue, which is the alignment of the interest of poor people in poor countries with the interest of citizens and taxpayers in the rich countries. And that's a collective action failure or a collective action problem, a problem of the commons, as Laurie put it, that we will need to resolve together. Is that alignment of interest between poor people in poor countries and the taxpayers in all the countries. And when we talk about this collective action, we're talking about agency. We're talking about people as citizens. And one of the problems that we are up against, and here I'm following up on Stephen Lewis' first keynote speech on the first day and about his need to speak truth to power, but also on Richard Horton's point about liberty and agency. If people are at the center, if people are key as both users and citizens, then freedom of speech, freedom of information, freedom of the press is a key element to drive collective action. And here is the difficulty that we are facing today in a world that is increasingly facing the challenge of isolationism is how do we create collective action? How do we create agency? How do we create that freedom of information that would allow people to have the lively, open, transparent debate that would lead to decisions that are science-based and get the consensus of all the citizens and are going to work for all the citizens and lead to solidarity. And we have a problem. Here is freedom of press, and you see that the countries that have free speech, free press, freedom of information are in green. The ones that have less so are in yellow, and the ones which are considered not free in terms of freedom of the press are in purple. And what is even more difficult to envision is that right now this citizen's voice is actually decreasing. We see a significant deterioration of freedom of speech and freedom of press over the past few years. In purple, as you see, the countries that are were already not free, still it is deteriorating. Countries like Syria, Eritrea, Rwanda, Congo, Russia. But then even countries which used to have reasonable level of freedom of press and freedom of speech, you see deteriorations too, like in Mali, in Nicaragua, in Honduras. So we really not only have a challenge of isolationism, but we have a problem of power. We have a problem of concentration of power. We have a problem of possibility of expression of voice towards collective action. So what do we do? Reaching the SDGs will require politics. They will require collective action and accountability. And people's agency is the key, as people are the owners of their own health, as users and citizens. So freedom of information, contestability, debate, science are central to quality of information. Quality information is contestable information. Science is anchored in debate, as well as transparent debates that lead to collective action. So let me finish with the words of Nelson Mandela, where globalization means, that it often does, that the rich and powerful now have new means to further enrich and empower themselves at the cost of the poorer and weaker. We have a responsibility to protest in the name of universal freedom. Thank you very much.
I was asked to reflect on the important theme of health and justice by using Kenya as a case study, and in doing so analyze the role of the judiciary as a fundamental institution of governance. As most of you may know, Kenya's 2010 constitution as a modern and a very progressive Bill of Rights. And on the whole, the Constitution itself reflects a social democratic vision of a Kenyan society. The Bill of Rights are so the ingredients of the right to health. It's the right to life, the right to food, the right to education, the right to work, right to housing, clean environment and sanitation, the right to clean and safe water of adequate quantities for all. In sum, this Bill of Rights signals a movement towards making the right to health a public good and not a commodity for sale. Like in many countries of the world, the tension between the vision of health as a public good faces serious economic, ideological, cultural, and political challenges. Systems that put profits before people and profits before the people's health are the dominant ones in the world. Judiciaries are slowly becoming institutional actors in the development of a jurisprudence that reflects the vision of the Constitution. In Kenya, the Constitution also states that the implementation of these rights will be progressive and would depend on the state of resources in the country. And the courts are, however, posing certain questions in this issue of the state of resources in the country. If our elite, for example, steal, raid, waste resources, and this is people's taxes, foreign grants, aid and loans, should the state be heard to say that it has no resources? If the national resource is stolen through corruption, are used to buy assets in foreign countries through what has been called the illicit economy, is the connection between international and national elites in denying the citizens of the world health as a public good established? And the illicit economy, and here I mean corruption, piracy, money laundering, human trafficking, trafficking in human parts, counterfeit, drug trafficking, illicit financial flows, etc. World Economic Forum has estimated that this economy is worth over $3.5 trillion. And no wonder some people call it a member of the G8. And it becomes ever more powerful going forward. The Kenya judiciary is in the process of establishing a division in the High Court in Nairobi called the International and Organized Crimes Division. There already exists a division for dealing with corruption. In the former, the idea is to deal with the counterfeit economy. It's well known that in our country, counterfeit economy negatively impacts the health sector. Counterfeit drugs are the cause of deaths for malaria, typhoid, diabetes, high blood pressure, cholera, and others. If the judiciary has to be effective, the Kenyan state must stop paying lip service to the vision of the Constitution. Health will never become a public good if the elites continue to give oxygen to the illicit economy, steal from the country while investing in private hospitals that turn health into a commodity to be bought by those who can afford it. Given our decentralization and democratization of political power in our country from the center, some counties have embarked on pilots to ensure universal health care to its inhabitants. The counties now have resources, and some of them are using these resources in an accountable and transparent manner. Health for all cannot happen unless there is equitable distribution of resources in the nation, in the region, and on the planet. If CUGH call for health for all is to be realized, then I've given some of the challenges we have to deal with as a planet. Global solidarities on this issue are important, and so are the global solidarities to protect the resources of the countries and their people. I know I have simply incited the pessimism of the intellect, but I wanted also to excite and incite the optimism of the will to change what makes our planet inhuman. I agree with historian Eric Hobsbawm, who has written, "Our world risks both explosion and implosion, and it must change." That change is going to be the greatest political project of this century. And that's how we are going to achieve our goal for health for all. I didn't go into the solutions. I guess that's something we can debate. Thank you very much.
Well, thank you all for sharing your, I think, appropriately sobering thoughts about kind of where we are and what some of our challenges are, and the contours of some of those challenges. You know, I think, Dr. Mutunga, it's incumbent on those of us who sound more like me than you, who have American accents or who come from the global north, to recognize that you know, the challenges that you diagnose in your own country often do not originate in your own country. And so it is incumbent on us to help solve those as well. And I also think, and yes, it's incumbent on those of us who live in countries that weren't on your kind of penultimate slide showing the retreat in so much of the world of the freedom of press and the reliable free flow of kind of verifiable information, to also recognize that we have those challenges in this country. And Laurie, you know that I think there is an excuse my language, very special place in hell for Andrew Wakefield, and I'm horrified that he is currently kind of wreaking great damage in Houston after having wreaked unconscionable damage in the Somali immigrant community in Minneapolis, and just continues to go higher up on the leaderboard of kind of Dante's circles of the Inferno. With that, and since Dr. Mutunga, I think, had a good segue into where I hope we can focus the conversation on the stage, and then kind of very much kind of with all of you, really is towards solutions. And yes, I thought I would start with you because of your role at WHO. Kind of when you kind of had your framework of science, money, and politics, and kind of saying now it very much is a question of political will as to whether or not we will move toward UHC and ultimately achieve UHC, not only in terms of kind of insurance coverage and risk protection, but also actually building systems that kind of people can rely on for reliably good kind of quality care at the primary kind of and tertiary levels. Kind of what do you see WH role is in doing that, and do you think you have kind of the political credibility to be able to do that at this moment?
Well, thanks. Certainly, I mean, WHO as a multilateral UN organization also faces a lot of challenges in today's world. I mean, the multilateralism is not that popular these days, and the UN is certainly very heavily criticized. But it is because of this globalization, this globalized economy and this globalized world we live in, that we need more than ever a WHO. It used to be that you could live in a country and you were not affected by what was happening in other countries. It's no longer the case because of transport, because of climate change, because of environmental issues. There is no place to hide on the planet from a pandemic. There is no place to hide from the effect of climate change. So we need some kind of institutional setup that tackles common goods, some kind of global government. And at this point, the UN is what is closest to that. And yes, it has challenges. It's not working as well as we would all like to. But in a way, there is no choice, because that's an issue of survival for us as a community of human beings. So, in my view, WHO is relevant more than ever, because we need to build that collective action. We need all the countries on board, even those countries who are going through these phases of isolationism. They need to get on board because we have common problems. So that's the first one, is the sort of being this platform, this convening agency that brings all the countries together is more important than ever. I think that also that agency where science is valued is very important. And the reason I'm sort of really today showing this data that come from Freedom House, but they also come from Reporters Without Borders, is that science, as we know, is anchored into disagreement, into contestability. It's about discussions. It's about people having different views, and this is how we move. It's Copernic, it's Galileo, it's Pasteur. It's people who were scientists who actually broke the mold and were thinking differently from others. And it's very important that WHO keeps being this also common place where science, anchored in science, in which even when facts or when alternative facts are discussed, that yes, well, they are discussed. Right? And they can be places of legitimacy and that actually can sort of approach veracity with the kind of transparency and legitimacy that is needed. And then the third point about universal health coverage is, as we know, universal health coverage is a social contract. So it's for every society to find a way to make it work, because it's about solidarity between healthy to sick and rich to poor. And that social contract is anchored into history, it's anchored into institutional legacy. We know this country is struggling with that social contract, big time, but many countries are struggling. And I think one of the most powerful, in my view, instrument that we have for universal coverage is citizens' platform. Thailand has this national health assembly model. In Europe, my country, France, has what we call the Estate General of Health. Right now, it's happening right now, in which you have a national conversation about what is it that we want together. what is the soft spot in which we all agree on how we're going to go forward. That spot of collective action. So that really for us is an instrument as WHO to really assist countries and be there to develop those citizens' platform, to develop that debate that is anchored in science, but it's also anchored in fostering collective action, eliciting the views of people, and giving agency to those who are excluded, because that's what universal health coverage is about.
Laurie?
Well, I'm struck by a couple things. The 10% of GDP of the planet spent on health happens to coincide with the 10% of dark money that has disappeared from taxation. So perhaps if we could extract that wealth and put it back into the global economy, we could cover some of the costs of all of this. But I'm very struck by a couple things. First of all, at the local level, in Kenya, for example, the distribution of wealth within a family oriented around health will very much be gender biased and very much be biased towards whoever is in charge of the hierarchy of the family. And if you have a huge dependency on out-of-pocket payments for health, which, let's keep in mind, a lot of people are talking about universal health coverage. Universal health coverage that covers 5% of the cost of health and you still pay 95% out of pocket, to me that's not UHC. That's just highway robbery. And it's highway robbery that still will say the family hierarchy will decide for whom do we spend that money. Do we spend equally on little girls and little boys? Do we spend equally for the Maasai versus the residents of downtown Nairobi? And in terms of the global scale, you know, we have a country like India claiming it's striving for UHC, but national spending on all health ranks on a per capita level as one of the worst countries on the planet. And we're supposed to imagine that India is giving universal health coverage with some kind of quality health to all the people of all of its caste system in all of its richest and poorest states, so that a resident of downtown Bangalore has equal access affordably to health to somebody in Uttar Pradesh who's of the lower castes? I don't think so. It's not reality. We're all smoking something if we imagine that that is what is unfolding. So when we say we want more country control, let's keep in mind, what countries are we talking about? What kind of governments are we talking about? There's a reason that so many of the counterfeit drug producers of the planet are sitting in two places, India and China. And there's a reason that the majority of all those counterfeit drugs are ending up in 35 countries located on the African continent. And that Kenya, for example, and Nigeria, and even South Africa struggle every day to know whether or not they've got substandard formulations in the anti-malarial drugs they've purchased, or are they actively distributing drugs at government subsidy that are promoting drug-resistant parasites. And so when I look at this across the landscape, I say, look, we have one tier of responsibility challenge right now. That's those of us that live in the rich world in donor countries or traditional donor countries. Can we, number one, set a better example for the world of what health is for our own people? We're losing that battle here in the United States. Can we, number two, get universal access to health coverage affordably for all our own citizens? Again, we're fighting that battle down and dirty on Capitol Hill in the United States. And secondly, can we continue the flow of resources? You know, we have a phrase in medicine, physician do no harm. When we started the PEPFAR program, I wrote in 2003, all right, here we go. Just keep in mind, when you put a patient on a form of care that's meant to be chronic care for life, you have no right to withdraw that care, because that becomes physician doing harm. You just killed them. And we've done the experiment with HIV. We know if we take you off the drugs, you die. You progress quickly to AIDS. It's the rare case that doesn't do so. So we have a responsibility in the rich world to say, all right, we put you on these drugs. We guarantee you we're there for you
until you really can do self-sufficient coverage of your population. At the next tier, we have all the BRICS countries, the new wealth nations on the planet, who ought to be self-sufficient and ought to be striving to provide the highest level and highest standards of universal health coverage to their people. China's trying to make a lot of claims about what it's achieving, but what I've seen on the ground, China has a long way to go. And we have to ask ourselves, why is the highest rate of violence against healthcare workers outside of war zones committed by Chinese people against Chinese health practitioners? Something ain't going right there. And we have to ask ourselves why Brazil is struggling so hard. They've got it in their constitution, guaranteeing health to all their people, and they're struggling so hard to control yellow fever, to control Zika, to control chikungunya, to control HIV, all of it, and that with a government that is committed. And as we go down the tiers to the new middle-income nations that still don't have middle classes and that are struggling to make, retail pricing for drugs and vaccines that they no longer can get discounted through Gavi and the Global Fund and so on, how will they make this transition, and can they really sustain it? And then finally we get to the level of the family in the poorest of countries and the hierarchies within those families that determine what does UHC really mean at the family level? What does UHC really mean at the village level? Who gets it, who doesn't get it, and who does that out-of-pocket payment go to cover?
Well, I think, Laurie, when you ask us to imagine, I think we're all very grateful to you and to all of the science kind of driven and literate journalists who are helping to ensure that we don't actually have to imagine, because you are reporting what is and is not happening on the ground. And many of kind of the most heroic are those very much who are within the countries, from the countries, and speaking indeed truth to power, to kind of return to Stephen Lewis, to their own governments. And so, Dr. Matunga, like listening to you kind of talk about the juxtaposition between the Constitution, which has a right to health and to all of kind of the supportive, enabling requirements to ensure health, housing, kind of a clean environment, et cetera, but contrasted to the reality for so many people in Kenya. How do you kind of take what Agnes and Laurie have talked about kind of at a global level and think about how that is translating in either positive or negative ways kind of within Kenya, and what do you think kind of we need to know about kind of how that's being translated at the family level, to kind of, I think, Laurie's appropriate reminder that kind of we should always be kind of focused on kind of health outcomes as the greatest kind of arbiter of whether or not we've been successful, but also kind of at the government level, and sort of what do we need to know, and kind of what do you think particularly Agnes should know as she thinks about kind of her work at WHO, to really understand where our efforts should be focused to ensure the Kenyan families are being helped and not hurt by kind of the global aid architecture.
Yeah, thanks. I think constitutions are about countries deciding what is in their interest. It's a debate where the countries start from the premise that the status quo is unacceptable and is unsustainable. And then they go around seeing how they are going to deal with that issue. And that's why it's a vision, it's an aspiration. And so once the country is very, very, very clear about that vision, then politics kicks in. Because even that vision is a contested terrain. There are people who are pushing it, there are people who are against it. In Kenya, there are people too who are against the progressive aspects of the Constitution. So it's an interest, it's a national interest that doesn't exist in a vacuum. But I believe that if there is a political leadership that attempts to implement that national interest, there could be progress, going forward. And in terms of that interest, in my view, is when Kenya negotiates with the West or China, we have a national interest that, given the geopolitics, given the status we have in the world, but we could be negotiating. But at the moment that doesn't happen, because it's all about commissions, is about corruption. It's about the resources, as I said, being wasted, being stolen, and corruption. And this alliance, this very, very unholy alliance between our elites and international elites. So that's politics. For me, is important. But I also think that the people are also important. I think you talked about that particular aspect of stakeholders, because I imagine if, and I'm quite sure that, some Kenyan thief has invested in probably Chitopa, Kansas, because I think they are avoiding the center, like New York and other cities. It's very, very, very important, I think, for the people of Kansas to know that that investment has resulted in deaths in Kenya, because it was probably money that was supposed to build a hospital, money that was supposed to build a school. And that's why I think the solidarities, among people become important. That realization that, we're all suffering. Whether here, where there's no universal health care and other places. So we need this people-to-people solidarity that is based on information, and that is based also on countering narratives that are in the West, for example, that terrible things only happen in the South, when actually terrible things happen in the South and North. And that will be the basis of, these solidarities. And they're very, when you look at the world, you see how these solidarities can happen. South Africa went through a program called, or a protest called Fees Must Fall. Because young people basically said that it's becoming too expensive to have, quality education. But in the US, I think in the 70s, the students here wanted, there was a movement that I read where students wanted wages, for schooling. And it's borrowed heavily from the project on housework, what was it? Housework is work and needed, wages. So there are a lot of those that can be the basis of these, solidarities. We have got to change mindsets. I think WHO should look at one county in Kenya called Makueni that is piloting this universal health care. They started with people who are over 65. It has worked, and now they're looking at this. It's a beacon may be a beacon in the middle of nowhere, but it's worth looking at because the resources they get, they have a counter agenda, and they are doing this. And that's important because there are resources in the world countries if they are not wasted or stolen.
Well, thank you.
It's worth remembering that Kenya is a country where the proudest institution that stood up to corruption was the Supreme Court, and that your Supreme Court, unlike our US Supreme Court, called a corrupt election and said to have a second count. And bravo to that.
Well, I want to open.
Thank you.
I want to open the floor to questions. I think we have microphones scattered about. If you have lots of questions, I would ask you still to just pick one question because I want to try to get to as many questions as possible. And I just want to say what a pleasure and a privilege it is to listen to our panel. And I hope that Dr. Matunga is correct and we're moving to a place of greater solidarity. And since you mentioned kind of young people being on the fore of this, I just have to exploit my position as the moderator to say how proud I am of all the Parkland students and March for Our Lives here in this country. So I think we'll just start at the far kind of stage left. So you, sir.
Jim Tilch from George Washington University. First, thanks. It was a great panel and very informative. I'd like just to ask the panel to respond to a issue that I think we basically ignore when we talk about development activities that's well reflected both in the BRICS and low-income countries, and of course the degradation of our own capacity here in the United States recently. And that's our gross underinvestment in regulatory capacity and regulatory performance. You know, it's wonderful to have all the positive and well-meaning policies at the highest level, whether they're driven by WHO or any other agency, but unless there are on the ground agencies that actually can enforce and regulate policies, it doesn't make a difference. And to me, India is a great example of that, where, you know, the medical care system is basically, the private system is almost completely unregulated, whether it's pharmaceuticals, whether it's actual delivery of care. So I appreciate your comments on whether or not regulatory capacity should be in our big piece of our agenda.
Inez, do you want to go? 'Cause I'm sure you've thought about that from a norm perspective at
yes,
WHO.
and I can only agree with you, but I think regulation is exactly one of these common goods. Regulation doesn't happen through the market. That's exactly why we need regulation, is because we have market failures. And anything that requires regulation requires agreement of all of us in a particular society. So again, this is for me one example of the point of failure of collective action and the importance. And I think maybe more than ever, we need to think about politics, but the question is poor politics. How will politics work to actually get the kind of regulation that will lead to the welfare of the entire society and not only benefit a few?
And I would just say, I think in some ways, this is a question that this audience and this organization is particularly well positioned to answer, because I think we have to be taking account of how we think of appropriate regulation and how we train the next generation of public health workers and officials, as we think of training the next generation of people who will run for political office, as we think about training the next generation of bureaucrats with a positive sense, kind of not a negative sense, doctors, nurses, kind of all healthcare practitioners, and anyone who may kind of want to work in this space. So I think you're absolutely correct that it should be kind of more prominently on the agenda. So, yes.
Hi, can you hear me? Quentin Ash from Vanderbilt University. I'm looking at your slide of the free press and the non-free press, and I'm kind of struck with how useful that still is when we look at our own free press, where it has got us. Particularly, people live in different information universes. We have Fox News propagating misinformation. Are there perhaps other indices we could use, like an accountable press, a responsible press, or something like that? I mean, are there such indices, or should we be working towards them at least?
Well, I was actually looking at Agnes's charts and thinking, well, those are out of date. We've got to change the American position and status when we have a president of the United States that actively encourages crowds to go beat up the journalists in the back of the room and calls the Washington Post and the New York Times fake media. Obviously, I'll be speaking in a couple of weeks here in New York for the March for Science. I'll be one of the speakers, and I can't imagine that we're at a point where just saying science is a system of finding truth, that is in and of itself a controversy now in the United States. It's phenomenal. It's phenomenal. But I think the real challenge for public health practitioners, and something that I think is woefully underfunded and studied in schools of public health, is to really seriously look at why public health keeps losing battles in health communications against the likes of Andrew Wakefield, or against the snake oil salesman on the internet who's claiming, don't take a vaccine, take my magic elixir, or the conspiracy theorists who manage to convince people that an anti-malarial drug will kill them, or what have you. And I think that's the challenge for all of you that are in academic public health, is to really figure out systems for studying why the battle keeps getting lost, and where the resources should be deployed and where the training should be to get ahead of the curve on all that, especially before we have the next pandemic and the lies start pouring out that actually cost lives.
And we know that it's an even split on Facebook between vaccine-related articles that are shared that are actually kind of science-based and those that are the opposite. So it is a challenge of significant magnitude. Dr. Mundaga, I just want to give you the chance, if you want to answer that question too, from a Kenyan perspective, how you think about trying to encourage kind of science and fact-based reporting and the kind of privileging of such reporting, because I know that kind of fake news has been a real challenge, often with quite deadly consequences in your own country.
Yeah, I don't think I have anything useful to add, really. It's a limitation. Lawyers, although we say we are learned, we're very, very ignorant of other disciplines. And this one of science is one I expect.
I think we all can learn from that. We should all not comment on things we don't have anything to comment on. Yes.
Hi, I'm Yingxi Zhao from University of Washington. I'm a master's student, and my question is for Dr. Laurie Garrett. You mentioned several times China in your presentation. So in your perspective, besides as a potential emerging donor, what are experience for China in terms of achieving universal health coverage and health development can be shared to other countries, considering many of those developments are achieved due to China's distinctive government implementation agency, like those characteristics, which are really hard to achieve in many other countries?
Well, China has a real challenge ahead of it because you have so much going on at once. You have an aging population, so the health burden is shifting, and it's getting more and more expensive to the government. And then you have a huge discrepancy between rural and urban availability and the quality of care and everything. And then finally, the Belt and Road Project means, I was in a big meeting in Hong Kong in December where there was a lot of talk about that the Belt and Road means that more and more of the resources of China for health should shift out to Kazakhstan, Uzbekistan, Tajikistan, and so on, down the Belt and Road and take the Chinese achievements in health out to the rest of the world. And then I think finally there's quite a vehement tension in China between the traditional health practitioners and the Western-style health practitioners, with a lot of the traditional health in China never having been subjected to the scientific method. And frankly, for many of the herbal approaches, there's no dose-response curve. Nobody knows what the dose is that you're getting in a given whatever it may be. And I think we saw it play out in worst-case scenario with SARS in 2003. Now, 15 years later, how much improvement has been made that would actually mean equitable and safe access to healthcare for all? I just go back to, if China cannot resolve why there's so much violence against healthcare workers, that's demonstrating a level of rage from the population directed to the people that are, paid to save their lives. What's going wrong there? What's the basis of that rage? It has to be addressed, and it can't be addressed by repression. It has to be addressed by identifying the cause and solving it. Please.
Thank you very much. Bradley Dreyfus from University of Arizona. Thank you all very much to all the panelists. My big question is coming from the perspective of my recent understanding of there being a 30 trillion, yes with a T, $30 trillion transfer of wealth from the baby boomers to the millennials. One of the fundamental differences between boomers and millennials is the millennials want to see social impact. So why haven't we as a global health community moved towards more of a creative finance model, thinking much more about innovative approaches to actually showing return on investment, both socially and economically? And how might you see the way forward in doing so in a consolidated way? And thank you.
I think I get all the easy questions, right? Maybe a couple of reflections on your question. I think first, we need to remember that in the 20th century, we've lived through the most incredible expansion of wealth in human history. I mean, what has happened in the 20th century has been an incredible shift in which we've seen first what Angus Deaton calls the Great Escape, which now is becoming the Great Convergence. So child mortality declining, fertility declining, life expectancy increasing, and with that, population increasing in a massive way, and driving economic growth through the demographic dividend and so on. So we live in an area of wealth, right? And still the poor countries are getting wealthier now. And we see, you were showing, Laurie was showing the poverty data declining. So we know how to create wealth. And we also know, we live in a society which is incredibly innovative. And in a way, there's an acceleration of innovation. Largely, I would argue, because we have market forces and because we have liberty, right? In which people can acquire skills and they can be innovative. The key question, I think, in your question is redistribution. The key question is politics is about distribution of resources. And sometimes people come to me and says, well, we know that UH is political, but how do we measure politics? There's nothing easier than to measure politics. Look where the resources are. Look how they are distributed. Look at the pattern of taxation. Who is taxed? Who contributes to the pot? And then where does the public money go? So yes, there's ample space for innovative mechanism, but they are profoundly in the hands of that political movement about what drives the distribution of resources.
I would just add, again, because these are schools of public health and this is an area where we need a tremendous amount of research and innovative thinking, is that we don't have solutions to market failures. And the entire pharmaceutical industry is a giant market failure. The diagnostics industry is a giant market failure. The medical technology industry is a giant market failure. None of it follows Adam Smith's supply and demand principles. And as more and more Americans are developing forms of cancer where the offered treatment is $200,000 a year for the rest of your short life, we have to ask, what are altogether new models for creating incentives for medical innovation, pharmaceutical development, vaccine production, and so on, that will incentivize and at the same time create affordability and quality access. One thing is very clear: shifting to generics is not the solution. It's an interim step. But you look at the generic industries, especially in India and China, and they're just as dependent on the profits of Viagra and Cialis as we are. They're just as likely to end up going for antipsychotics and antidepressants at the expense of producing yellow fever vaccine. And we're in a crisis in the world where we're running out of the basics that have saved lives for the last several decades, because nobody finds profit in making streptomycin anymore. Nobody finds profit in making cholera vaccine anymore. And we have to, I think the real innovative ideas that we're waiting for, we're looking for the blockbuster out there, is who's going to come up with solutions to these issues, incentivizing development and production, but at affordable price points.
And I just want to emphatically agree with both Inez and Laurie, and say there have been real efforts to innovate, but none of them have been at sufficient scale. So while I'm incredibly thankful for everyone who's bought anything from what was Project Red and now is just Red, it's represented less than 1% of the total funds raised by the Global Fund. Right, so just on a scale basis, our efforts to innovate, while meaningful, deeply meaningful for the now in excess of $650 million that kind of Red has aggregated together to help prevent mother-to-child transmission in the 6 qualified countries, it still is such a small percentage of what kind of governments have contributed to the Global Fund. So I think I just couldn't agree more strongly that this is an area where we need real innovation to try to help understand kind of what will kind of in the best sense resonate in the global solidarity that kind of Dr. Mutunga kind of envisions for us in the 21st century, such that some of those resources can very much manifest that solidarity in practice to solve some of the market failures that Laurie talked about.
Can you all please sit down with your business schools, your economics departments? The collective genius is high among public health people, but you really need the skill set and the knowledge base of basic business and economics brought to bear on all this.
So we need Dr. Mutunga's lesson of being candid about what we don't know and complementing what we don't know with those who do know it.
Can I just raise one thing that's important, I think, that hasn't come up in the panel and I felt has been missing here in this discussion? My name is Oliver Fine from Weill Cornell, and I think that we in this country have to, in fact, be thinking of a improved Medicare for all of our citizens, a single-payer national health insurance program that could, in fact, begin to negotiate with the pharmaceutical industry more directly for price and make a real universal coverage system real in the United States.
Well, of course, that's the Bernie Sanders position. You have to keep in mind there are many people on Medicare who are not getting the care they need and can't afford the copays. And some of the more recent Medicare analysis is showing that copay costs for a lot of Medicare recipients exceeds their mortgage in any given month. So let's be very careful and not just call for, take a crappy thing and give it to everybody. But I would go the next step and say, look, we have our domestic issues that we need to solve, None of them can be solved as long as a certain individual is in the Oval Office. But that is separate from the global discussion we're having. And I think it's really important as Americans to not, in animal behavior, we have the danger of anthropomorphizing and projecting human behavior onto all the animals we study. I think as Americans, we have a tendency to look at the whole world through the prism of our country and our cultural experience. And I think we need to be very careful about pulling away from that and saying we have a responsibility to our own people, but it's a very different set of issues from what's going on the global plane.
Well, I agree with that. We have 4 minutes left, and since we have, oh gosh, now 5 people standing, maybe you could ask your questions really briefly, and then I'm going to put the burden on the panelists to answer kind of whichever ones they feel most qualified to Dr. Mutonga's point, most compelled by kind of where they want to kind of spend these vanishing minutes. And so now I'm going to stop speaking and let kind of all 4 of you ask your questions succinctly, please. We'll start over here, then kind of maybe both of the women in the center aisle, and then you finally. So please.
Hi, thank you so much for the panel. My name is Arsh Lal. I'm a fellow with the Global Health Corps, working with InterHealth International and the Frontline Health Workers Coalition. My question, the panel has brilliantly talked about a lot of important topics, but what I feel wasn't addressed well enough is the power of youth in this conversation as we move ahead. I know we mentioned how we have to start training our next generation well enough, but also as the practitioners and the leaders and the decision makers as we move forward, we want to make sure that they are pulled in early on and understanding these concepts. I've written about this as well, that the power of UHC should really be a call to action for youth. So what are some ways that we can really meaningfully engage youth early on in this endeavor?
Thank you.
Hi, my name is Patty Garcia. And my question, it's an easy question again for Agnes, okay? And we have been talking about governance, and I agree completely with you that in this time, we really need WHO. And we're talking about universal health coverage. But how can we, and that countries take the contract and they have to see what they could do for universal health coverage. How can we assure that this concept of universal health coverage, especially because it usually is associated with an essential package of services, doesn't cause more disparities than the ones that we have? So why in some countries that universal health coverage means maternal health and infectious diseases, but they will die from cancer, and in other countries it is considered? And this is something that I think, and I would like your opinion, WHO needs to take a lead on.
Okay, thank you. Please be very brief because we literally have a minute left.
My name is Michelle Dupero. I'm from Stanford. My question is about youth. We've talked a lot about gun violence in Parkland and how they've finally been able to get some cracks in the political divide that we have here. Has the WHO made any efforts to include regional offices of youth representatives, under 35, under 30, to have an actual tangible voice in policymaking?
Okay, thank you. And finally.
My name is Jerry John Nuto, and I'm a PhD candidate at Drexel University. My question is to Dr. Sokat or Agnes again. There is a belief that World Health Organization respond to issues affecting low-resource countries is different from issues affecting developed countries, as we've seen in response to Zika and Ebola in West Africa. What is your response to that? Is that true, or there are some political issues that hinder World Health Organization?
Right. Well, thank you, everyone, for your questions. I think, Agnes, if you can tackle the WHO-related questions, and then Dr. Mutonga and Laurie, maybe you can talk to the youth questions.
Well, I will very quickly say that, first of all, the question on youth, but this is also for everybody. We have created a partnership which is called UHC 2030. So if you type UHC 2030, you Google it, you will get to a website in which we bring all the partners who are working on UHC together as the platform for health systems. And there we have different groups, different collaboratives that work on specific issues, some on human resources for health, some on pharmaceuticals, some on data. We also have the collaborative on governance, and then the health financing collaborative, which is the P4H group. And you're really welcome to engage. And we have actually a platform for engagement of students. We have associations of medical students, association of nursing students who are part of this platform. And we really encourage all the youth organizations to really join. Because that's also the question on training, is that one thing that we haven't mentioned in this conversation is the incredible shortage of human resources that we are having. The demand for health labor largely exceeds the supply today, globally. So I cannot overemphasize the fact that on average, globally, money is not going to be an issue. We know that there is a relationship between gross GDP and health expenditure, and it's an exponential relationship. The richer the countries are, the more societies choose to spend on health. And we are getting to the vertical part of the curve. The problem is, what are we going to do with this money? And how is the market going to react, particularly on health labor, because most countries underinvest, have not realized that, in fact, this is a growing economy that is going to be much more than 10% of global GDP tomorrow. And then on the specific question of what WHO does on essential services, then I'm really happy to report we are working right now on what we call the Universal Health Coverage Menu, which is sort of really trying to bring together all the evidence we have on interventions that work. And we're not limited to maternal and child health at all. It's really about evidence, it's about science. It's looking at those interventions that really have a benefit. It's a benefit in terms of survival, of mortality reduction, but it's also in terms of quality of life, in terms of financial protection, in terms of equity. And we hope to have this really out on an interactive website by the end of this year. But really, it's definitively cancers, hypertension, cardiovascular disease, they have to be part of a package of universal health coverage. And it's really about the country, it's about the collective action to choose what is that the public purse will pay for everybody.
So I know we're out of time, but I want to give Dr. Matunga and Laurie just a chance to share final thoughts, and particularly if you want to comment on the youth question. Dr. Matunga, do you have anything else you'd like to share?
Just to thank everybody. I've learned a lot from this panel.
Thank you. Laurie, do you have any thoughts on the youth question, or
I mean,
in
look
30
at me,
seconds
am I
or less?
supposed to talk about youth? My fountain of youth drained a really long time ago. But I guess all I would say is, as somebody who's at the bottom end of the baby boom generation, you know, there was a time when we were the high school students that marched in protest and did pretty remarkable things. And I'm proud of a lot of the things that we did for civil rights, stopping the war in Vietnam, and so on when we were kids. But it's funny how aging and mortgage payments turn people into much more conservative, selfish forces. And I just really want to anybody in this room that was born after 1990, I just want to say I'm really goddamn sorry. We're giving you a planet that's going to go well over 1.5 degrees C climate change long before 2050. We're giving you a planet where there's no place without microplastics. We're giving you a planet where there's no species that doesn't have antibiotic-resistant microbes and plasmids in it. We've really screwed this planet up for you. And I'm going to do everything in my power, as long as this body will hold together, to fight on your behalf. But I also think you're going to need a much better toolkit than the one you've got at hand.
Well, on that optimistic note, I think kind of we have to end maybe where Dr. Matunga left us in his remarks, in that our only option really is to have a meaningful and not just a rhetorical sense of solidarity as we tackle these challenges that are arguably intractable. But I just was not born to be a cynic, because I think that cynicism is the reservoir of those who want to protect the status quo, and I have no interest in protecting the status quo. So I just listen every day to the voice of Jim Kim in my head telling me that optimism is a moral choice. And it's one that I choose to make, and I think by definition all of us choose to make, otherwise we wouldn't be in this strange hotel room that seems to be out of time and space with its lights on a Sunday afternoon. And so kind of may we all go forth together in solidarity and optimism, and please give our extraordinary panel a round of applause.